something good. Maybe we start. Hello, everyone around the world. We are today in a webinar looking at the engagement of private laboratories in TB diagnostics. We have a strong panel with great presentations in preparation, and we will also have a discussion. I'm happy to introduce everyone in a minute, just to let you know that we have a 1-hour webinar. There are going to be 3 presentations, then some comments, and then a time where we will have discussions. The presentations will all follow one another directly. So if you have any questions, please put them in the Q&A. That will allow us to collect them all for the moderated discussion. So to start off the topic of today, as everyone knows, we have a large private sector in many of the high TB burden countries, and people seek care in those private sectors that often don't have the quality TB diagnostics or medication available. And for that reason, there's real importance on engaging all of the private sector, and specifically laboratories, where we are having the first diagnostic test. So today we will hear about some of the challenges and the opportunities by engaging laboratories, private laboratories specifically. And we will hear about examples from Nigeria, India, and the Philippines. And from India and the Philippines, we hear 2 examples of how a consortium has been built to actually put private laboratories together. So before I go into further details, let me tell you who is today on the panel. First of all, I'm really pleased to introduce Taufikat Ali. She is a program manager at IHVN in Nigeria, and she has experience in clinical and public health practice, and she's currently leading the Global Fund programs on private sector engagement in Nigeria. Then next we'll be speaking from India, Arnab Pal, who is the senior manager in the Clinton Health Access Foundation. He has experience in pharmaceuticals and in management consulting companies, and right now is leading within the Clinton Health Access Initiative the engagement of the private sector within India. And then the third speaker today will be Lalen Mortera. She works in the Family Health International 360 in the Philippines. She has 20 years of experience as a private provider herself, and is currently leading the initiatives within FHI on lab engagement and private sector engagement in general. Then we have with us Dean Grindal. He works for Cepheid in the Global Access team, and he's joining us from Singapore. He has a large experience within laboratories in private and public health, and is a biochemist as a background. So his perspective will be really interesting as well. And I'm pleased that Professor Madhupai will be moderating the panel. He's joining us from Montreal this morning early for us. And I'm also introducing my colleague Joel Clinton, who is helping in the background. So we moderate the whole webinar. So with that, and without further ado, I would like to ask Taufikat if you would like to try and start sharing your screen so that we can pop it up and that participants can also look along while you're talking. So please go ahead, share your screen, Taufikat.
I'll do that now.
Is it working? Is it working, Taufikat?
Yeah, just a minute, I'll be on.
Okay. And in the meantime, for anyone, feel free to use the Q&A during the presentations or at any time, and we will be picking up the questions for the moderated Q&A. Okay, go ahead, Taufikat.
Okay, so good morning, good afternoon, good evening, everyone. I'd like to say thank you to the TBPPM Learning Network for inviting me to speak to our experience in engaging the private sector in Nigeria. Here goes my outline of the presentation I'll be making. So as a way of background, the Institute of Human Virology, IHVN, is a PR on the Global Fund public-private mixed grants in Nigeria for TB. So you could say IHVN is sort of an intermediary organization that has been contracted to engage and organize the private sector in TB service expansion. And this we're doing across the formal and informal private setting in 21 states, which gives almost about 60% coverage We go across different types of facilities, the faith-based facilities, private for-profit, the community entities such as the community pharmacists, the PMVs, patent medicine vendors, the traditional healers, and what we call the standalone laboratories. These are private diagnostic labs that are not embedded within a health facility. And all of these arrangements, the engagement is done within a hub and spoke sort of model of arrangement. I'll speak to that shortly. And it's important to also know that IUN has extensive experience in laboratory support, laboratory setup, having set up the diagnostic network for DRTB diagnosis in Nigeria. So as a preamble, what's the rationale for engaging the private sector, especially in a country like Nigeria? So given our national outlook, Nigeria is a high TB burden country, and more worrisome is the high burden of missing TB cases. And given that 60% of the population would visit a health provider first for any health care, perhaps because a lot of private facilities are there in the community, proximity, it's convenient, and there's this perception of better quality of care in the private sector compared to the public. So all of that, and then of course from our statistics as a country, we know that before now the private sector is a place where there is very low knowledge of TB, and for those who offer any form of TB service, adherence to international best practices is not always there. So given all of this, it becomes quite expedient to expand, to the private sector in terms of TB service provision. So looking at what we had before the private sector engagement in terms of the laboratory network in Nigeria, looking at this from the national reference laboratories to the zonal ones and the state labs, and even to the peripheral facilities. You can see that a lot of them, mostly over 90%, were in the public sector. There was really no participation of the private engagement, private laboratory provider for TB diagnostics. So what we have done in the hub and spoke model I talked about is to also bring in the big laboratories, engage them, and make them a hub where they're able to provide some screening service and diagnose TB cases, and then refer them for further treatments in the health facility. And so they're a hub where other health facilities in the periphery send patients. And this effort has yielded about 14% increase to the number of facilities, standalone private laboratories that now provide TB services in country, apart from those that are embedded within private health facilities that we have engaged. So what is our experience like? What has it been in the last 2.5 years that we've been in the private sector business? So I'll say the major challenge is the access. We know that the private lab man is at best a small to medium scale enterprise. So his purchasing power is quite low compared to those in the public sector who under the national procurement and supply chain are able to enjoy a higher purchasing power and pooled procurement is done. So for the lab, private lab, access to reagents, to commodities, and in the light of the recent COVID-19 pandemic, essential PPEs are not easily available, are not easily accessible for the private man. And what this means is, an increase in the cost of TB service. And of course, with all of this is infrastructure, the road network, equipment setup, power that is necessary to build, the laboratory structure upon is not readily available. And where they're available, maintenance support is usually a huge challenge for the private man. So he experiences, frequent breakdown of machines, downtime is often, a big problem for him. And in terms of standardization of practice, we don't see that much in the private sector. Human resource availability. I'm sure everyone would agree in the private sector, the numbers are usually few, and where they're available, the capacity or the type of cadre of staff engaged is usually low. And coupled with that, they experience a lot of, turnover of staff, going and coming. And they do not have the support that we have available in the private sector where there's continuous mentorship and support. So that creates a huge gap of human resource, for health in the private sector. And I'll say the big elephant to eat in engaging the private sector is looking at the profits or the cost of service. Of course, the average private man is there for the money. He's there to make profits. And in Nigeria, TB services are free. So we've had, that huge challenge of trying to balance the need to provide free service at a minimal cost to the patient, while also keeping in view the man, the provider, who needs to make profit, who needs to break even and make profit. So with that, we've had to experience a lot of competitive sort of incentive package that we've had to put on board, because there are other partners as well. So for instance, for TB experts, the gene expert machine is used to perform TB test, Xpert MTB, also for hepatitis. So if you're given incentive of $1 per test, and the man from the hepatitis program provides him $5 per test, what happens? Your TB samples will suffer. So that's a huge challenge we've also had to face. And of course, service awareness, creating awareness that these services are available. He doesn't have the means to do that. And of course, underlying all of this is the need to move the samples. The substrate for the lab is a sample, either blood or sputum or whatever. So where the samples are generated in the facility needs to get to the laboratory to be tested. Oftentimes you have, inaccessible road networks, very difficult terrains, and, the need to maintain cold chain when the samples are transported, is usually not, readily available. That support for the private man, he can't afford it. And of course, we kind of emphasize, how important data is. And because of the low human resource availability, it's always burdensome to the private laboratory man to have to fill all the registers you need to provide. So what do we think we can do differently? From my experience, we think first and foremost, it's important to ensure that there is coordination. The private laboratory structure is also brought under the engagement, under the radar of the national coordination support and the regulatory support. So umbrella bodies like the Guild of Medical Lab Directors need to be actively engaged in the PPM steering committee at the national level, the state level. We need to also invest in community sensitization. So it doesn't make sense to have spent so much setting up a private laboratory with machines, and then it's not utilized because the community is not aware that it's even there. So that's another area where we tend to neglect. So huge community sensitization to drive demand and create utilization is important. And to underline all of this is the need to clearly state out in clear terms of engagement, who is responsible for what, the roles and responsibilities, of the private provider, of the partner coming into support, of even the national program at the state level. And without, overemphasizing this, capacity building is key. There must be, and not a one-off capacity building, but there must be that sort of surveillance to check once there is a gap being created by exit of a staff who has been trained, we must, intervene to train the next person available. And this should be an ongoing thing. And importantly, access to updated information, guidelines, SOPs is very important for the private sector engagement. They need to be abreast of what is happening internationally. So supporting them to attend scientific conferences, presenting papers at scientific meetings is also a good way to ensure that they also stay abreast of what is happening, and they're also refining their practices, learning from what they do and what is happening internationally. And in terms of addressing the challenge around commodity supply, without integrating them into the national procurement and supply chain, it's going to be difficult to cross that hurdle. So it's important that they enjoy that support from the national structure and also support for equipment maintenance. So they should be brought within the fold of the national structure for purchasing and equipment maintenance. And importantly, external quality assurance. Right now, we have a lot of public facilities, being part of the national TB EQ exercise for TB, diagnostics. We're trying to see how much more of the private facilities we can bring on board. That would, ensure that they are on their toes. They're looking at the quality of what they're doing, and they are also, it gives confidence in the quality of the data and the results being churned out from the private facility. And of course, you can see that picture at the bottom of the slide. we've had to pilot this and we're scaling up right now. So we had to procure motorcycles and engage riders. So they visit the very hard to reach terrains, they move samples, ensure cold stain, and take it to the laboratory and retrieve the results and return it to the facility. So with that, and there's an electronic dashboard that monitors, the whole pipeline. And once there is any blockade along, the pipeline, a red flag is raised. So this is also, ensuring that, there is adequate sample, because in some facilities, you have empowered them, they have all they need, and samples are just not coming. So we need to ensure that the samples get to the endpoints. And lastly, very important, we should emphasize from day one, that is a collaborative partnership, with the private facility, with the private partnership, private engagements. So they see themselves as being part of the response to the national, TB control. And as such, whatever they need to do, they're also happy, they're committed. And for those who do really well, it's always a good thing to recognize them. It could even be from the high levels, from the National Ministry of Health, from the TB program. They really like that a lot as well. And as I said, the incentive package is important. It has to be competitive. It has to be attractive. So it's important to streamline whatever incentive is available, playing out in the field, so that you're sure that your samples are not neglected for more lucrative, or more paying partners. And we need to spell this out in terms of performance-based financing. Are we paying per test? We need to spell that out. We may even go ahead and further incentivize to say, if you are able to turn out, shorten the turnaround time for samples for results within this period of time, you're going to get more incentives. So these are ideas that have really worked on the program that really helps in constructive engagement of the private sector. And access to diagnostic equipment, very important. If we're able to procure from the national program, from a program, and give gene experts machines, give X-rays free to the private laboratory diagnosis. If you're able to replace a 4-module machine with a 16-module machine, he has access to accessories. There's prompt attention to equipment breakdown. All of this, will encourage him to have that commitment to work for the program. And of course, giving him some leverage as well, letting him have access to, surrounding health facilities. So we've tried to sort of create that network where the lab man is able to also speak with health facilities around him. They send patients to him to do other tests apart from TB. That widens his client base, and that helps a lot. And of course, lastly, electronic, platforms. Anything that will reduce the burden on the private provider in terms of documentation, reporting, that is always welcome. So these are areas that, from my experience, we think if we're able to look at them, it's always helpful in improving the engagement with the private facility. Of course, the learning curve, we're also learning from other practices around the world. Thank you for your attention.
Thank you, Taufika. That was an excellent presentation and really good to see how you colorfully outlined all the challenges and also the opportunities within Nigeria. I would like to now ask Arnab Pal to please share your screen and move us into India and hear the experiences from your side. Thanks, Taufika.
Thank you. Thanks, Taufika, for getting us to a great start. And thank you, everyone, for inviting me for this talk. So I'll talk about our experience in India with the IPAC program. IPAC stands for the Initiative for Promoting Affordable and Quality TB Test. This is broad, I think, topics that I'll cover. So just to get started, I think IPAC was started towards the end of 2012, early 2013. And the situation at that point of time essentially was the cost of GeneXpert test, and generally, the recommended TB test was really high. That resulted in a scenario where the uptake for these tests was really low, which resulted in kind of other serological tests and other tests being used in the private sector, which again, I think led to a vicious cycle of more demand for GeneXpert tests from labs, low uptake of platforms, and low market volumes. So literally, it was like this vicious circle where, I think, where this entire market was stuck in a low volume, high price kind of setup. And specifically, if we talk about the challenges that we see in the Indian private market, and while some of these are still true, I think generally there's low use of sputum tests by private providers. Even till date, a lot of private providers prefer diagnosing using X-ray and other tests. I mean, sputum smear. So, we, I think the usage of I think sputum tests is generally historically, there had been a lot of reliance on serological tests. That was when I think the new guidelines came into picture, and I think because of knowledge gaps and I think historical practices of private providers, I think there's still kind of continuation of usage of those tests. The lab network or market in India is fairly fragmented. So again, India has a very large private sector base for providers as well as for laboratories. There are various types of labs. There's an estimate of around 8,000 to 10,000 laboratories operating in India. So while there are few players which kind of have pan-India presence, a lot of laboratories are localized, just operating in the specific city. And then kind of there's a limited awareness about these tests. In terms of opportunities, if we think about it, I think I think there was an opportunity to kind of sensitize and move providers from serology to sputum test. I think there was an opportunity also to kind of aggregate labs and kind of organize the market, given the nascent stage that this market was in 2012, 2013. Laboratories also have their own, I think, networks of sales teams and marketing teams to engage with providers. I think there was also an opportunity to kind of leverage that channel of to kind of engage with providers. And then, I think we saw an opportunity to kind of move from a high price, low volume market to a kind of mass market pricing model where, you were high volume, low pricing model. And I think for companies, there was a chance to kind of increase this. So what did we do? I think, so what is IPAC in essence? It's essentially a consortium where we got manufacturers and distributors on one side. So we've engaged players like Cepheid, BD, Biomedu, Carl Zeiss, and others, and kind of got them on board along with the large private labs who are operating in India. The value proposition was fairly straightforward. I mean, for manufacturers and distributors, they agreed to offer their HBDC pricing to private labs, which were otherwise available only to governments. They agreed to kind of offer that to private labs, and private labs return agreed to kind of cap the price for these tests for their patients. So essentially, we tried to kind of, again, what that resulted in is that, for example, in Xpert system, I think costs for the labs kind of reduced by almost half, I mean, both for the machine as well as for cartridges. And this obviously resulted in labs agreeing to kind of lower prices for patients. So for example, again, the GeneXpert test, before IPAC, for private sector players, patients, it would cost around $67 to $70 on average. That got reduced to half, to around $33. Similarly, for the LPA and midget, we were able to kind of reduce the prices for patients. So, and to kind of monitor this entire system and kind of the network, we had a governing council which had representatives from laboratories, from the community and others, and Chai kind of was acted as a secretariat to kind of bring all these players together. Why did labs and manufacturers sign up? I think, for them, how we saw it is that, this was fairly unprecedented where, laboratories agreed to kind of some kind of a voluntary price control. I mean, generally, since these are profit-making entities, they're obviously looking at maximizing their profits. I mean, if you have to kind of hazard some guess, I think for labs, they needed a serology replacement because those tests were banned. There was a government mandate and gazette which kind of made notifications compulsory. We also saw that, labs might have benefited or seen an advantage where they perceived that since their input costs reduced, they would see some value in terms of greater uptake and greater utilization. Competition is fairly the strong competition, and we've seen market consolidation in India amongst labs. So I think perhaps that might also be, a motivation for them to kind of come on board on the IPAC platform. Pre-marketing, I mean, through IPAC, we've been able to support a lot of demand generation work, and I'll talk a bit about that. But also perhaps there's the social obligation as well. I mean, this is for kind of a good cause, and I think uh, the downsides as such were fairly limited because we were still taking care of profits and margins for laboratories, but we're just kind of capping that and not like keeping it completely. For manufacturers, I think through the IPAC platform, I think there was some confidence that the price cuts would be passed on to patients. Otherwise, there's always a danger that labs might kind of try to maximize their profits. But in this case, because we had the mechanism of IPAC, there was some confidence that these would be passed on to patients. There was also, I think, strong possibility of expanding usage because the market was trapped in this high price, low volume game. I think manufacturers saw limited uptake of their products, and I think there was an opportunity for IPAC to kind of scale that up. And I think we have to kind of look at what have we achieved till date in IPAC. I mean, it's been more than 8 years, 7 to 8 years. So right now, IPAC is truly a nationwide network. I mean, we have more than 300 laboratories part of the network, and these labs have multiple collection centers. So we have like literally all states and all districts having at least an IPAC lab or their collection center present. Over the last 7 or 8 years, we've seen a significant improvement in, I think, both gene expert testing, but also of the LPA and culture test through the IPAC platform. So currently, approximately 80% of all gene expert tests in the private sector happens through labs which are affiliated to the IPAC network. And finally, I think what we've also seen over a period of time, there's an increasing convergence of the commercial price of the gene expert, basically labs which are offering gene expert outside the IPAC network and within the network, perhaps because of competitive pressure and pricing pressure created through IPAC network. So over the last few years, I think we've seen the gap reduced from around $33 to $100. You have to look at in terms of what could IPAC not achieve. I mean, well, fairly successful, I think there have been a lot of challenges. I mean, if you look at the volumes, in 2019, there were a bit over 300,000 tests done through IPAC labs. But if you look at the overall TB burden in the country, that's a fairly small number. I mean, the estimated 6 million or more presumptive cases, so 300,000 is a fairly small number. And if you look at actual patients, the gap is actually very large. So while we've been able to increase adoption, I think there's still a huge, huge market out there which we've been unable to tap through IPAC. We've also realized that demand side is actually fairly complex. I mean, I think there is a lot of resistance to change, both in terms of provider behavior and in terms of investments required by labs to actually grow this market. We also saw some challenges in kind of notifications from labs because of challenges around data systems and data quality. Some labs struggled to kind of provide notifications. And at the end of the day, despite the reduction in cost, it's still a fairly expensive test. I mean, in India, where the average monthly household income is still over $50, the test still costs around $30 to the patient. The demand side, as I mentioned, has been a significant challenge. I mean, I think we tried to do a lot of things to kind of address that. We sensitized providers through medical seminars and clinic visits, a lot of focus group discussions, interventions. While a lot of these had some kind of, we saw some impact, I think these obviously increased the cost, for the intervention, and the result in terms of how much volume did they actually drive was not clear. So I think demand creation is I think something which needs to be thought through. It's not just a supply side intervention which can help, but I think similarly, I think the demand side has to be really thought through, and we need to kind of think of a system wherein we are kind of engaging both patients, providers, as well as laboratory, and kind of creating this win-win situation. And if I have to kind of talk a bit about the evolution of IPAC, I mean, over a period of time, we've expanded the IPAC from just TB tests to include other tests like the HIV, HPV, HCV assays as well. This, I think this resulted in kind of a greater value proposition for labs, because labs which are now, let's say, investing in a gene expert platform, they could do multiple tests and move to a multiplex kind of model rather than just run for TB test. So there was greater incentive for them to kind of invest that upfront money gene expert platform. However, I think the uptake we are seeing is kind of restricted to some of the smaller laboratories and hospitals, and not some of the larger players, which may have competing platforms for running these tests. The IPAC model is also being kind of expanded to other countries. I think Pakistan ran a project recently, and Dalaine will be talking about Philippines, which is kind of following a similar model through a different link. And we've also tried to kind of integrate the IPAC work within the broader private sector engagement work, which is happening in country through global support. So, the GEAT project, which was around engaging private sector, we've tried to integrate the laboratory components through that and ensure that, I think there's some sustainability of this intervention beyond being a funded project. Let me pause here, because I can kind of hand it back to Petra and Dalaine for take it forward. Thank you.
Thank you, Arnab. That's an excellent job in summarizing a wonderful amount of experience and lessons from India, and very impressive. Thank you so much. Dalaine, I think he gave a beautiful introduction in already saying that the Philippines is looking at a similar model. So please take it away.
Okay, so can you hear me and can you see my slides, Petra?
Yes, perfect. Both of them perfect.
Okay, so thank you very much. So, well, we were inspired by IPAC India, but when we were pushing for the idea in the Philippines, we wanted to make it our own version, which we call it, we Philippinize the consortium model. So the next slides that I will be sharing with you is about the collaborative efforts to increase TB diagnostics in the private sector in the Philippines. So to provide a context to my presentation, of course, we know that the Philippines is one of the high TB burden country, and it has a public health threat in terms of TB. There are about 1 million Filipinos with active TB disease, so that would be roughly 1% of our population. And based on the 2020 Global TB Report, we are actually number 5 next to India, Nigeria, Indonesia, and Pakistan. And we're contributing to 7% of the global underdiagnosed people with active TB. In terms of mortality, we always say that there are 3 Filipinos dying every hour due to TB. And that makes actually TB as the highest killer of infectious disease in the Philippines. Now, when we talk about catastrophic cost, and we define it as household income spent, 20% of the household income spent for TB treatment and diagnostics. For those who actually consult the government sector, they even experience 35% of this catastrophic cost. Now, if they consult in a private provider, this would even be higher to as high as 70%. So what was the country response to these realities? In 2017, the Philippines actually joined the UN high-level meeting, and it committed to find and treat 2.5 million Filipinos with TB by 2022. So for you to have this, you have to test 3 or 4 times in order to find patients of Filipinos with TB. So the strategy then was business not as usual, roll out massive rapid TB testing. That time it was GeneXpert in public facilities, increase treatment adherence, and to increase mandatory TB notification and engage private sector. However, we noted that not all would prefer to go to the public facility. And the 2 speakers actually mentioned about the major reasons why this is so. Due to they prefer confidentiality, this is their preference, etc. And in the Philippines, we noted that 39% would actually prefer to consult the healthcare provider in the private sector. So when we noted this, we cannot definitely fight against the preferences of patients if we want to tide them over. Another analysis that we made is that, yes, private patients would prefer private facilities. But in terms of the diagnostic capability of laboratories in the private sector is actually very minimal. There are about 488 facilities already offering gene expert services, but they were all predominantly in public sector, and only 4% or only about 20% in the private facilities. Unfortunately, they were mostly offering commercial pricing, such that in a Lancet article published in 2018, it showed that the Philippines actually had the second highest globally in terms of pricing for gene expert in the private sector. And this is something that would really be a turn off for doctors to really prescribe gene expert testing left and right. So because of this high price, 90% of patients notified by the private sector ended up clinically diagnosed. So when we talk about only 10% bacteriologically confirmed notified cases, we think about the patients managed in the private sector. Are they really TB patients? So we might, there's a tendency for overdiagnosis because of reliance only on chest X-ray or clinical grounds. At the same time, we also do underdiagnosis for possible drug-resistant TB because they are not doing the rapid TB testing where we will find about the rifampicin resistance. So with all this backdrop, we were able to have a value proposition to all the stakeholders in the provision of TB diagnostics in the private sector. We need to align our values if we are to engage them. And one thing that we need to respect is the patient preference. We need to not fight against them, but we need to make that choice affordable. And I think this was the common rallying point between laboratories, even patient groups, and also the doctors to be able to make that decision affordable. And indeed, at the end of the day, be patient-centered. But for it to be affordable, we need to realize and analyze the profit margins across the players, from the supplier, distributor, and laboratory. And we need to understand and analyze what is reasonable across these players. Only then can we be able to come up with a model and make it that supporting public health, especially in offering TB diagnostics in the private sector, can indeed be a sustainable business model. So this is what we call the win-win partnership, and this is actually our talking points when we convened influential players in the private diagnostics in the Philippines. We started with a governance structure that was very democratic. We consulted the key stakeholders along the way. We came up with a charter that made sure that it was aligned with the interest of all the stakeholders. We identified a convener that would be the intermediary or the middle person between all these stakeholders, between the laboratory owners, the doctors, and even the Department of Health. We invited them in our consultative meetings. But what is very crucial is the market analysis that we did in parallel to really look at which drives cost in the private sector for the pricing of a gene expert. And these actually informed subsequent negotiations for concessional pricing with the supplier and eventually with the distributor. So finally, I think we are the youngest consortium. We just launched last February 26 last year, and we're barely a year old. So we call the consortium providing quality diagnostics within our reach. So like India, IPAC model, we also ask our consortium members that they will be eligible to concessional pricing as long as they agree to provide uniform pricing to patients for goods that were procured through the consortium. They agreed that they will provide quality assured diagnostic services. They agreed that they will notify to the Department of Health, National TB Program, their data on laboratory testing, and they agreed to be monitored, especially for their compliance to pricing. So this would lead to our vision as a consortium to contribute to the Philippine government's quest to improve public health management and care by leveraging innovative approaches and market-based model to procurement, at the same time service delivery in the private sector through public-private partnership. So when we started, we, of course, by default, we reached out to PhilCat. This is the Philippine Coalition Against Tuberculosis. It's a national coalition of the TB stakeholders in the Philippines. There are 63 members, member organizations where most professional societies belong to, from the internists to the generalists to the pulmonologists and infectious disease specialists. So PhilCat agreed to be the convening agency and at the same time the secretariat. FHI actually supported the capacity building for PhilCat to be the convening agency. So during that time, only GeneXpert was available as the rapid TB diagnostic test in the Philippines. So we started to reach out to CFID. We wanted to negotiate with them, and finally they agreed to provide concessional pricing to the Philippines. We also involved Macare, the local distributor, because they are the provider for the quality, for the servicing services for GeneXpert machines. I think one of the key facilitating factors in the consortium is the entry of PPPI. This is a government-owned and controlled corporation. They agreed to be the default procurement agency for the consortium for other tests where there are no existing local distributor. Now, definitely the establishment of the consortium was with technical support from, of course, from the TB Innovations and Health System Strengthening, which is leading the technical assistance in the country for private sector engagement, managed by FHI 360. And this is funded by USAID in partnership with the Interactive Research and Development. So with the negotiations, we were able to bring down the cost by 73%. I think this is the biggest decline in the pricing. So we ended from second highest globally to the third cheapest in the world. So from a average of $155 to $42. We're envisioning that this $42 may still be high, but eventually we're hoping that with more volume, we'll be able to reduce it further in the next coming years. So currently, these are the current membership of the consortium. We started with a few labs, mainly targeting the bigger high volume hospitals, level 3 hospitals, and the value laboratory networks and large laboratory networks. So currently, we're only 17 members, but we do receive a lot of queries for membership. And from this, we actually shifted to a web-based platform for our full procurement. Also for, we have a portal here for patients who would like to look at the current directory for the geo mapping of consortium members for access to the GeneXpert at concessional pricing. So the next steps for the consortium is to expand membership nationwide through focused promotional activities of the consortium to hospital and physician networks. We would like as well to expand the diagnostic portfolio of the consortium beyond GeneXpert and definitely beyond TB tests. Through the consortium, we were able to facilitate the introduction of GeneXpert Ultra. So it was through the consortium that GeneXpert Ultra was made available first. And because of this, the government, the National TB Program, decided to also include GeneXpert Ultra in their portfolio. So we would like also to support the wide dissemination of the latest National TB Program Manual of Procedures and the Clinical Practice Guidelines, recently updated, because it is now recommending the use of rapid diagnostic tests like the GeneXpert. We're currently supporting paperless private laboratory notification through the consortium, and hopefully we would explore the inclusion of rapid TB testing in PhilHealth. PhilHealth is the national health insurance of the Philippines. Currently, we are optimizing financing through private HMOs to fund diagnostic testing using GeneXpert. So that's it. Back to you, Petra.
Thank you, Lalan. That was a very comprehensive presentation. Congratulations on all the achievements. Before we open the floor for some comments and discussion, I would like to ask Dean Grindle to give a few comments from your point of view, and then I'll ask Madhu to take over straight after to moderate some of the main questions. Dean, please go ahead.
Okay, thank you, Petra, and thanks everybody. I kind of wanted to comment on two things really. One, which is our experience working with Lelaine and the team in the Philippines. There were some very interesting lessons learned with that interaction. And then I'd like to comment on an internal process, which some of you are aware of, and I'd like to kind of share with others. It was obvious from the beginning that, there was a clear mandate from all of the stakeholders within the country, that this was a project that, had to succeed. And, with all the challenges that came up all the way through, we kind of took them on the chin and we kind of worked through them. So it was a very good collaborative effort. Some of the challenges have already been expressed by the other speakers as well. Kind of having this long-term sustainability, having just TB alone, and Lelaine mentioned that just a moment ago in her summary, having a kind of broader offerings, to keep the private sector engaged, both short-term and longer term, I think is also kind of important. Something that's kind of important from our side, as a vendor that contributes to, the private sector engagement, and that's to have, a secretariat or a consortium like those that have been explained by the other speakers, because that helps us, establish an equal playing field on both sides of the fence, so that, when we set, expectations and offer concessional pricing, then of course, it's kind of important that that is kind of passed on to the patient. After all, we're here to solve TB. The other interesting thing, from our experience with working with the Philippines as well as India and Pakistan and Nigeria, is this whole question of demand generation. And that is something that internally too, we're kind of trying to work through as well to see how we can help with that. And that kind of leads me on to the second comment. Some of you I've spoken to at length, Petra included, about, what is it as a vendor, CEFIT can do, to facilitate private sector engagement in a more open and I guess faster, more manageable fashion. So what we've been looking at is, the whole procurement method, the different types of private sector engagements that exist, the ones that we have in Nigeria, IPAC, Pakistan, and so on, looking at those in great detail and seeing, what obstacles exist, along those customer journeys, and see internally how we can make those a lot less difficult, and that we get to the result a lot quicker as well. So that, the expectation from CEFIT's side is that we will have that completed in the next few weeks, and I'm sure at that point we'll be happy to share, more of those activities. Those are the comments from my side. Thank you.
Thank you, Dean. That's great. Madhu, go ahead.
Yes. First of all, thank you so much for this really rich session. I loved the cross-country experiences. I think if I had to kind of summarize what I've learned from all of you, plus my own work, is that private health sector without intervention will really undertest for TB. That is like a rock solid truth that we are just not able to do much about. I mean, any number of studies show that they will continue to use non-specific medications and antibiotics and whatnot, and delay testing until it really becomes very essential. So without intervention, under-testing is guaranteed. And even with intervention, under-testing is still a concern. Microbiological testing is simply not happening at the level we would like. And then without intervention, costs of any TB test in the private market is very high. So it's kind of a vicious cycle. Because the cost is high, people are under testing. Because they're under testing, cost is high. And then the fact that until IPAC and initiatives like that came along, all special negotiated pricing excluded the private sector was a big rate limiting step. And it's kind of really wonderful that companies finally understood that and agreed to offer concessional pricing, provided there is a secretariat that can control or monitor the ceiling price, which is what Dean just told us, that their ability to participate is high if there is an intermediary like IPAC or any of your organizations to control the price. So in terms of the models, the questions, I think Taufiqat many people were confused about your model. While the IPAC model and the Philippines model is very clear, we didn't know whether you just bought GeneXpert machines and cartridges from Global Fund money and just gave it to a bunch of private labs and they did it to patients for free. Was that the model? Can you explain that a little bit more to us?
Yes, thank you. I think I realized that while answering the questions on the Q&A box. So yes, to make it clear, and as I've answered in the chat box, so the system in Nigeria is all through the National TB program. So whatever diagnostics, especially the more advanced molecular diagnostics that are available, the GeneXpert, the culture, the reference laboratories, all are under the national program. So procurement of the Xpert machines are actually by the National TB program, and that the National TB program will do an assessment to look at which public and private facilities have the capacity to, work on the machine, to maintain the machine and, do TB tests, with those machines. So the national program takes a decision, not even IHVN, but because we're partners working together, we sort of work together on all of this. So we also have a say. So, but the assessment is by the national program supported by IHVN to say, oh, there's this private lab. It is well structured, it is standard, it has good HR, and a lot of factors will come into play. Has it got the HR support to man that machine?
So the government gives the equipment to the private labs. What do patients pay? What do patients pay for?
Okay, so because again, TB tests, TB services are free. So if a patient goes to the private lab to do a TB test, it comes at no cost to that.
Okay, but then the question that is important to answer is, what do private labs get out of this for them?
So I did mention the incentive package. So even though the patient is not paying, someone is bearing the cost. So that the PPM grants comes, into play. So the grant is bearing the cost.
Okay. So I think
for every test done, we pay the private lab.
Okay. So the important difference between the Nigerian model and the Philippines and India model is that the Indian labs buy their own machines and they charge them money and they notify to the government, but the government does not give the Indian lab the machine or the cartridges. Okay, so yours is a very donor-funded initiative through the public system. Understood. So it'll be very nice. I think even Lalaine, while your model was clear and the cost reduction was clear, we did not get a sense of your volumes. We didn't know how many labs, how many tests. Same thing, Tawfiq, we don't know how many tests were implemented in the private sector. We don't have to answer them here, but it'll be nice if each of you could track your numbers, kind of like what Arnab showed. Show us the number of labs, show us the number of GeneXpert systems in the private market, show us the volumes of tests being used, and show us what those volumes look like when comparison to the private sector caseload. Because as Arnab showed, when you look at the total number of patients in the private sector, the amount of testing IPAC is doing is very small, even with all the price reduction, which kind of gives us a pause that no matter how hard we try, the high cost of the test itself and the market really prevents us from going full swing on this. So here I have to, at this point, Dean, ask you this important question. I'm sure you've been seeing all the advocacy campaigns around the pricing of the cartridge. You've seen the Reuters article. I think the frustration the TB community is having is as follows: that for 5, 6, 7 years, we've all through huge amounts of public investments, Global Fund, so on and so forth, we have large number of installed bases of the GX system, right, all over the world, including low and middle income countries. So when the COVID crisis came along, we were all hoping that those machines would be life-saving because everybody wanted molecular testing. And as you know, your system is hands down the easiest molecular system anybody can even dream of doing. But yet the high cost of cartridges and lack of availability of priority for low and middle income countries left everybody feeling let down that they could not really deal with this crisis adequately. So the high cost of COVID cartridge, HIV cartridge, TB cartridge continues to be, I think, a rate limiting step for true potential impact of your product. So what is it that after all these years, now 10 years since the WHO endorsement, right? We would love to see some thinking about how to make this product more affordable, not just for private, but also for public sector, not just for TB, but also for COVID, for Ebola, and for other diseases of poverty.
Right. Yes, I understand. I understand the comments, and we've heard them. Unfortunately, it's above my pay grade to have such decisions. But I think from the private sector point of view, when we're looking at what kind of packaging can be done, the pricing structure is something that we're looking at as a group. So we have representatives from Africa, from Latin America, Eastern Europe, Central Europe, and of course, Asia Pacific and India as well on this internal team to try and establish this. So it is something we're looking at, to build consistency across countries and regions and so on. The bigger picture, that would be a question for management. But I think that thank you for the compliments. CEPHID is very well committed, highly committed to the TB space. So I'm sure that long term we will continue to work together and hopefully flourish as a result and solve TB. So I think. So sorry, I couldn't give you. Sorry, I couldn't give you better news.
No, it's just that $30-40 even after these Herculean efforts.
Correct. Yeah.
Still is not reaching people who we really want to reach, and I think that is the overwhelming message we are getting, that all our efforts will not reach us. So the quick question for all of you, Arnab, kudos to IPAC for already going beyond TB, and Lalaine, you're already thinking about going beyond TB. I think the same thing should be true of Nigeria, more so with COVID, because the disease platform is truly multi-disease. But what is the plan for each of you to start putting MolBio or TrueNat, now that it's WHO endorsed, into your IPAC model? And will that be a cheaper alternative to GeneXpert? Arnab, what is your thinking there? Quickly, please.
Sure. Yes, I think that's something which we want to do. I think greater competition is also helpful and kind of makes the market more competitive and I think increases volume. So yes, I think definitely we are looking to include the MolBio platform, and in the future, if the Abbott and Roche platforms come in the picture, I think we definitely want more players in the IPAC network.
And Lalaine, any plans for MolBio inclusion in your network?
Yes, actually, as we speak now, there are ongoing negotiations with them. So hopefully we'll be able to share once we agree on the pricing structure.
And Taufiqat, anything of Nigeria for MolBio?
Oh, yes, absolutely. During the last grants writing phase, which was just concluded in the last year, this was a hot discussion on the table, the TrueNat. But because at that time, there wasn't pre-qualification by WHO at that time, it wasn't something we could get approval for, but now learning that it's been approved, I'm sure this is a discussion the country will pick up, anytime from now. And we're hopeful that I think it's more of a point of care testing tool. So this is something we hope will really help a lot, because if you'll permit me to ask a question to Dean, so yes, GeneXpert has come to stay. We use it as a multi-purpose platform. But a lot of the challenge we have, because the system that requires, a lot of maintenance support, power, and all of that, and given our terrain, we tend to have a lot of downtime, modular phase, and all of that. And so the support for maintenance for the GeneXpert system, what plans do you have on improving on that? Why I ask this is, the turnaround time, the response time, when we call the CEPHID contractor in Nigeria to say, oh, a module is broken down, we would like, you to look at it. Is always, the response time is always so long. So every quarter, we're having hundreds of modules that have failed and we've not responded. So, what plan do you have in improving that maintenance system?
This is a valid concern you've heard a lot before.
Sure. Yeah.
For high burden countries, the support is not only difficult, but also expensive.
Yeah. So there are huge investments being made in increasing our customer care base for high burden countries. In many African countries, they've kind of moved over to Access Care, which is, kind of service offering, which is the surcharge on the cartridge for low-income countries. And of course, we're looking at that in Southeast Asia and the Indian subcontinent as well. But in addition to that, our global customer service organization, you will see a lot of additional people being put in to all of the countries, as we speak. So you will see, a change in behavior and certainly a change in presence around the regions as well. So watch this space.
While we are talking about support, Dean, can I also mention to you a big concern that everybody has is that your distributors really jack up your prices. So it's kind of a night and day difference between what is advertised and what finally hits the ground. And it's been a very challenging situation to work with your distributors. Anything you can do to make them honor your HBDC commitments and pricing, I think is your responsibility in the end, because it's your name on the product, not the distributor's name. So there's a sticker shock between what we think we're going to get and what the price quoted in every country I've seen. Why is that? And why are you not able to control the distributor pricing?
There are many variables, at the distributor level. When things come in which are internationally procured through the Global Fund and all this kind of stuff, then of course the equation is straightforward. But once you have transport, and of course things are slightly worse now because of COVID and lack of transport offerings and so on, but then you have taxes, duties, financing and all of the other expenses, distribution within the country. So it is impossible to charge you at the same level. But we do try, to make sure that if things are very reasonable, we do check it with our partners as often as we can. But I would encourage, if there are things which are being noticed, then please, notify us, send us an email. You know where the local representatives are, and then we can check it out and correct it if possible. So we only know what we know.
And is there any chance, just as you were kind enough to include HIV and hepatitis in the IPAC program, and you offered the HPD pricing, could we do that for the Express SARS-CoV cartridge as well?
That's all of these additional tests we're looking at as part of this kind of internal process. So we're hoping that, as soon as, we have the opportunity that, we can include as many tests as we possibly can. Yes.
Which makes a lot of sense, because you want the private labs to monetize their investments, and then you want the overall volumes of your cartridges to go up. Express COVID cartridge has been quite expensive in many privatized countries.
And the limitations at the moment is that, because of the WHO consortium, all of the cartridges go there, for the emergency responses. So at least in the short term, the WHO consortium. Yes. So right now, we don't have, the opportunity to change that, but hopefully over time we can.
I think we are out of time, but this is such an exciting webinar. We probably should have done it for 1 hour, 15 minutes. Regardless, I think all of you have answered many of the questions in the Q&A box, but Petra will follow up and send out the Q&A answers to everyone. I'll just wrap up by saying that these initiatives are really important, but we are also seeing the limits of what we can do with the private sector, given the cost constraint that we are all feeling. And almost all of us are kind of still donor supported, donor driven. Whether this will organically happen and catch fire in the private market without any of us intervening is more of a stretch goal. Right now, a lot of effort needs to go in to even achieve this level of price reduction and this level of volumes. And if we didn't intervene, I fear that this will kind of degenerate into a very expensive test that only a handful of private patients can afford. So we are far away from the level of impact or saturation that we would like to see. But I think we are learning a lot by doing these and different models, and the PPM Learning Network is happy to share cross-country exchanges of this sort so that we can learn from each other. So the IPAC paper published in BMJ is one of the best summaries I've seen on what this might look like, its possibilities, its limitations. So please take a look at it. I put it in the chat box. Petra will also send it out to everybody. And if you can also publish your experience on how Philippines and Nigeria has dealt with it, describe the model a little better, show us more data, successes and failures. Like, everybody wants to know how you did EQA, because private labs are notorious. Some of them do EQA, others don't care about it. How did you tackle the quality assurance? All of them would be very valuable lessons for us as we move forward. So thank you so much again for all your efforts. And Dean, please carry the message from the TB community back to your Sunnyvale headquarters, that we are not really happy with this GeneXpert being an elite test, where it is still not reaching people with TB, which, as you know, is the lowest quintile in the economic scale. So we need some radical rethinking on this, and also other cartridges like Express. It cannot be that we have a machine, but we don't have a cartridge, we can't afford it. That's the I think the tension within the TB field we are trying to overcome. Petra, back to you.
You're on silent.
Yes, sorry, I was muted. Thank you so much. We are indeed a little bit over time, and I wish we had planned 1.5 hours, because clearly I would have loved to hear the reactions from everyone who has been presenting. What a rich discussion. Thanks everyone very much. I'm thanking the panelists for your presentations. All the presentations will be made available online. The recording will also be made available online. Thanks, Dean, for stepping in, and I think it's your courage to kind of have this debate in public with everyone. Maru, you did an excellent job in moderating, and I think this is where the discussion needs to be an open debate back and forth for us to all improve. And the point that each of you raised on the demand side, where we really need to bring the patient and the providers that are on the ground further into this discussion, where we can also have more of a voice from them towards governments where changes need to be made. So it's a full cycle of engagement of everyone, and I love that this kind of has kicked off a wider debate. So just as a few operational things for closing, we will have all of this sent out. The report will be available for you as well in a couple of weeks. As Maru mentioned, there are a few background documents, including a TBPPM feature stories on the consortium in the Philippines, which we will also share. So that is a quick glance. And yes, everyone who has further stories to share, please contact us. We'll be happily working with you to write them up and publish them for the full network. We will be posting everything later online on our website, the tbppm.org. And please come back to us in a month, where we will have our next webinar. I'm going to launch a poll for our attendants to get some feedback. So if you can please just answer 3 quick questions, that would be most appreciated. And in the meantime, I'm saying goodbye to everyone. Happy evening, happy rest of the afternoon, rest of the day. I'm wishing everyone a lot of goods, and we will see you next time. Thank you so much.
Thanks.